My lecture today is about cardiovascular diseases in the elderly population. As regards the objectives of our lecture are: identify cardiovascular changes in the elderly, identify the risk factor for cardiovascular diseases, diagnose and treat coronary artery disease, use different modalities for treatment, recognize that heart failure is a major public health problem in this century, especially in the elderly, diagnose and treat heart failure in the elderly, as well as know the specific treatment of heart failure in the elderly. Before we discuss the cardiovascular diseases or disorders in the elderly, we must identify that there are certain changes in the cardiovascular disease with progress of aging. These changes are called senility and not senescence and not senility disorder. The senescence is physiological changes occur with progress of age, opposite to senility, which is pathological changes occurring with age. With aging. So, as example of senescence disorder, tachycardia, sinus tachycardia, but up to limit. The heart rate in the elderly population may reach as a normal limit up to 100. These are senescence, but physiological changes rather than pathological. But as regards severe tachycardia, is sinus tachycardia, 140, 130, 150. This is senility disorder. Senility means disease. And so, what are the common disorders occurring with aging in the cardiovascular system? The common 8 disorders. These are what is termed cardiovascular syndromes in the elderly. Common pathological changes occurring with the progress of age. Number 1 is SA node, aging of SA node. SA node, as we know, is the pacemaker of the heart. What about this, the progress of age? What about the aging process occurs in the SA node? SA node, aging process means sick sinus syndrome, alternating tachycardia, bradycardia syndrome. And the only line of treatment in this case is pacemaker of the heart, permanent pacing. Number 2, the deposition of abnormal processed amyloid in the myocardium, which is termed the aging of the myocardium, as well as aging of the brain in the Alzheimer's disease, deposition of abnormally processed amyloid in the brain cells. That is what is occurred in the myocardium, aging of the myocardium with deposition of abnormal processed amyloid, which means that restrictive cardiomyopathy. And restrictive cardiomyopathy presents clinically as heart failure. Number 3, what about the most common arrhythmia in old age? The most common arrhythmia in old age is atrial fibrillation, as well as lone atrial fibrillation as etiological factor. As we all know that thyrotoxicosis is a common cause of atrial fibrillation. Valvular disease, common cause of atrial fibrillation. Hypertension, obstructive pulmonary disease, hypoxia, anemia, all may lead to arrhythmia in the heart or atrial fibrillation. ischemic heart disease, post-MI. But as regards the atrial fibrillation in old age, the most common cause is idiopathic without any etiology, which is termed lone atrial fibrillation. The next question is what is the commonest type of heart failure in the elderly? The commonest type is diastolic heart failure. Diastolic heart failure is a common disorder in old age, and diastolic heart failure not diagnosed with ejection fraction. This type of heart failure is termed HFpEF, heart failure with preserved ejection fraction. This type of heart failure is diastolic heart failure, and it is the main cause of heart failure in the elderly. Again, what about postural hypotension in the elderly? Postural hypotension means reduction of systolic blood pressure and diastolic blood pressure above 20/10. This means that when the patient changes their posture, this means that the patient has postural hypotension. Again, this is the most common problem as regards the hypotension in the elderly. Postural hypotension. And this postural hypotension, the most common cause of it in the elderly is the antihypertensive medication. Next, disorders, the coronary atherosclerosis, which is a common problem in the elderly, as all we know, which lead to angina, any form of angina up to myocardial infarction. But in this case, in the elderly, the myocardial infarction, very common presentation in MI is silent MI in the elderly. And this is a big issue in the elderly. This may lead to sudden death without diagnosis. So, silent MI is expected coronary event in the elderly. For this reason, we call that the ECG is mandatory for any elderly patient, even as a routine checkup or as a maneuver during any deviation from abnormality in the old age, like slight drowsiness, like dyspnea, maybe cognitive disorder in the form of delirious state, all this epigastric pain, all this atypical manifestation of coronary artery disease and must be assessed as silent MI. Next, the commonest murmur in the elderly population, the most common valve lesion in the elderly population is calcific aortic stenosis. If during auscultation of the heart you demonstrate a murmur, you must exclude the calcification of aorta. And aortic stenosis, calcific aortic stenosis is a big problem in the elderly population. And the treatment may be sometimes by surgical intervention or valve replacement or balloon dilatations or catheter dilatation and so on. The next is the hypertension in the elderly. The most common cause of hypertension. Hypertension is a common problem in the elderly, but the most common type of hypertension in elderly population is systolic hypertension. And in this case, most of the hypertensive persons in the old age suffer from wide pulse pressure. You measure 170/70, 280 systolic hypertension. And this systolic hypertension leads to wide pulse pressure. And again, wide pulse pressure is a major risk factor as stroke complications. So, control of systolic blood pressure and narrowing of the pulse pressure in the elderly are targets. And the most important principle in the approach to cardiovascular signs and symptoms with advancing age is to recognize that the narrow homeostatic capacity in the elderly, in all aspects of life, psychological, neurological, pathological, electrolyte, acid base, renal, and so on. Narrow homeostatic capacity is a golden rule in the management of elderly population. This picture shows that the atherosclerotic process is a silent process. If we detect this progress from the first decade of life and from the fourth decade and so to the fifth and the last, and so on, we find that there is deposition of abnormal streaks of fat, maybe start from the third decade of life. And these pathological changes are asymptomatic. And this is the problem, and this is a big problem. This phase is asymptomatic. Again, with the possession of more dangerous fat lead to fibrous plaque start to be formed. Again, this is maybe asymptomatic. And the last step is the rupture plaque and the release of thrombosis, which may be travel to a distance away from the site of the lesion, maybe cerebral, maybe coronary, maybe renal, maybe peripheral, lead to embolization, and if cerebral stroke, coronary stroke, and so on, this will lead to devastating complications with end result maybe death. And this is the only maybe the symptomatic phase of this atherosclerotic process. So we need to diagnose early atherosclerosis and manage properly, as we know, to prevent the complication. We discuss now the preventive medicine and not the therapeutic, not the curative now, not the therapeutic of complication. We discuss preventive medicine, the prevention of complications of atherosclerosis. How can we prevent this complication? This is the picture of plaque. As we see, the plaque in the carotid artery. This plaque and plaque score measurement and the intima media thickness, IMT, measurement considered a good diagnostic modality and non-invasive technique in diagnosis. Plaque score as well as intima media thickness, and this were done by simple maneuver through carotid Doppler study. Not expensive, not invasive, and so we can do to confirm the diagnosis of atherosclerotic process, even if early. And if carotid suffer from atherosclerosis, this means that most probably coronary affected, as well as cerebral affection, as well as renal affection, renal vessel affection, glomeruli, and so on. The process of atherosclerosis is generalized, diffuse process, and not localized process. So we can demonstrate carotid Doppler and diagnose the early stages of atherosclerosis. And at this moment, we can do what is called preventive maneuver, preventive medication to prevent the catastrophe of a stroke. As regard the diagnosis of this is the coronary artery disease, angina, acute MI, acute coronary syndrome, ST elevation MI, non-ST elevation MI, and so on. The classification of now the term of coronary chronic coronary syndrome as well as acute SCS. There is CCS, chronic coronary syndrome, and MI by each types for the affection of coronary artery, either in the elderly or in the adult population. These are the traditional risk factors, as all we know: hypertension, diabetes, aging, smoking, alcohol, and so on. And the risk factors newer than the traditional: C-reactive protein, CRP, is a major predictor. High sensitivity CRP is a major predictor of the vascular insult in the body, like protein A, homocysteine, and as well as microalbuminuria. How can subclinical before occurrence of complication, cardiovascular disease be measured? Number one, as we know, as we said, the carotid Doppler, by carotid Doppler, as we see this slide. Number two, a simple maneuver by measurement of brachial blood pressure as well as ankle blood pressure. This is termed ankle brachial index, ABI. By in certain instrument or even by sphygmomanometer, we measure the blood pressure through the upper limb as well as through the lower limb, the ankle, posterior tibial. And the measurement, the lower limb is higher than blood pressure, higher than the upper limb. If we find that the ankle to the brachial less than, must be more than 1. Yeah? If less than 0.9, this means that there is peripheral vascular disorder. What is the relation between peripheral vascular disorder and coronary events? This is a vascular problem, and a vascular problem is diffuse generalized problem. And third one is the CT, computerized, what's called coronary CT, coronary angio. This is the third step. أكيد مش هنروح نعمل coronary angio لواحد ما عندوش حاجة، إلا لو ظهر بالدوبلر أو بالأنكل brachial something wrong. And the coronary artery disease. Angina, as all we know, the clinical symptomatology: weakness, dyspnea, maldigestion, palpitation, chest pain, typical chest pain of the angina, which is the retrosternal, compressing in character, or heaviness, sense of heaviness, refer to the left shoulder, and left refer to the inner aspect of the little finger. This is the typical presentation of angina. Again, in the old age, the presentation may be atypical. By ECG, depressed ST segment significantly to diagnose ischemia, and the cardiac enzymes in case of angina is normal. This ECG shows that there is depressed ST through the chest lead V3, V4, V5, as well as V6, with the inverted T changes AVL, one of the lateral lead, as well as depressed ST in the lead 1, which is this lead 1, because A is normal ECG. A is normal. B is ECG with ischemic change. What are the ischemic changes present? Number one, as regard lateral lead 1, AVL, V5, V6, or are with depressed ST segment and inverted T. So this is lateral ischemic changes. What about more finding? What about the lead? The inferior leads is somewhat normal. What about the anterior leads? Leads V3, chest leads V3 and V4 with depressed ST. So this is a case of anterolateral ischemic changes. but just coronary artery disease, just angina, and not MI. To confirm the diagnosis by treadmill and thallium scintigraphy or CT angio, and 24-hour ambulatory monitoring. Coronary angio is the last step to demonstrate these changes. Treatment is the correction of underlying risk factors plus nitrate and beta blockers. Intervention therapy in cases of multivessel disease by CABG operations. The symptoms of MI mimic the symptoms of angina, but severe, persistent, and not relieved by coronary dilator like nitroglycerin. Retrosternal pericardial stabbing, compressing more than 30 minutes, not relieved by nitroglycerin, associated with fever, tachycardia, apprehension, so on, radiate to the left shoulder and jaw and the left arm. Signs of MI may be faint heart sound, may be normal. The MI may present with normal signs, but may be associated with the changes in the heart sound S1, S2, change abnormal heart sound S3, S4, and may present with some murmur like mitral regurg or pericarditis if associated with, and fine basal crack if associated with left heart failure. ST elevation MI. What about changes in this ECG? Number one, the abnormality present in T wave in the form of peaked T wave as well as hyperacute T wave. What are the criteria? What are the criteria of hyperacute T? Number one, increase in the length more than the complex. As all we see, this is the complex, short complex, maybe about 4 small square. And the T wave is hyperacute, maybe up to 10 small square. This is called hyperacute T, and this is a sign in ECG of hyperkalemia. And hyperkalemia is a presentation of case of MI or other etiologies, but is a presentation of MI if associated with chest pain, apprehension, diaphoresis, sweating, and so on. What is next more than hyperacute T? The hyperacute T present in the V2 and peaked T, and hyperacute in V3, and in V4 you see the complex, the small complex, and this is the hyperacute T. And in case of again V5, but this is peaked T. So these leads are the septal leads, V2, V3, plus V4 and V5, septal, anterior, and lateral. So this is a case of query recent MI in this ECG, because the case might be hyperkalemic. But in case of hyperkalemia, we see the diffuse hyperacute T and not localized to certain leads. Plus some ischemic changes are present in the inferior leads, lead 3, as well as lead AVF, infero anterior ischemic changes. Again, this is the case of ST elevation MI with characteristic raising, significant raising of ST segment, and this case is inferior leads, lead 2, lead 3, as well as AVF, inferior MI, inferior STEMI. And this is to summarize the MI and the presentation. In elderly patient, number 1, MI may be silent. In elderly patient, MI may be diagnosed by only elevation of enzymes, cardiac enzymes, serum troponin, LDH, CKMP and so on by cardiac enzymes. Cardiac enzymes are mandatory in case suspected cases of MI in the elderly, plus ECG, plus CT angio or coronary case. And treatment of MI, as all we know, by, if the blood pressure is stable, by morphine, oxygen, nitroglycerin. PCI is the major modality in treatment, especially if the situation is available. Presence of cardiac case, not present in all the situation, you can diagnose MI in it. So if available, the PCI is the mandatory in case of acute coronary syndrome or acute MI in the elderly. What about the role of thrombolytic therapy in the elderly? Thrombolytic therapy in the elderly may be effective and may use no limitation as regard the age, maybe up to 90 years old, but avoid complications and take care from the relative and absolute contraindication if the patient has terminal renal disease, terminal hepatic disease, bleeding tendencies, malignancy anywhere, if the patient has recent peptic ulcer since 3 months ago, if the patient has recent operation 6 months ago, and so on. There are relative and there are absolute contraindication to the use of the thrombolytic therapy in the elderly. Take care during treatment. Again, heart failure in the elderly and precipitating causes of heart failure in the elderly: non-compliance, myocardial ischemia, MI, preadio or tachyarrhythmia, COPD, common disorder in the elderly, anemia, as well as hyperthyroidism, hypertension. These are the causes of the heart failure in the elderly. As we know, all the causes are common problem in the elderly. Diastolic heart failure: 30 to 50% of patients with heart failure have normal left ventricular systolic function. So don't depend on the ejection fraction to diagnose heart failure with preserved ejection fraction, which is diastolic heart failure. Diastolic heart failure more prevalent with age, more common in females. Asymptomatic diastolic dysfunction more common than symptomatic. These are some causes of diastolic dysfunction: functional and structural abnormality. Incidence of diastolic dysfunction is age-related, and heart failure due to diastolic dysfunction rises dramatically with progress of age. What are the problem of heart failure? Problem of heart failure. Heart failure is a big, challenging problem in the old age and in all population worldwide. More than 50% die within 5 years of diagnosis of cases of heart failure. 34 of NIHA class 1 and 2 may die within 5 years, and 42 of the decompensated cases may die within 5 years. About 45% of cases of cardiovascular deaths are due to sudden death. And of these sudden deaths, the most common etiology is the ventricular fibrillation. And this is the most common complications as arrhythmia in cases of decompensated heart failure. These are the classic physical findings of congestive heart failure as a vital signs: the gallop, S3, S4, basilar rails, pleural effusion in case of right heart failure, and classic finding in X-ray, again, increase the cardiac size, maybe curlis B, maybe curlis A and C, and so on. This is the classic finding in X-ray. This is the curlis B lines, which occurs due to interstitial pulmonary congestion. So this is the guidelines of diagnosis of the heart failure by either symptoms, by either ECG abnormal, by physical examination, as well as echo finding. As regard BNP or brain natriuretic factor as a diagnosis of heart failure, not of clinical use so much, but may be used as a progress of improvement or complications. So the main lines of diagnosis is diagnosis of heart failure. Number one, by clinical presentation of the patient's signs and symptoms. Number two, by the echocardiography, and ECG sometimes not effective. Some cases of elevated natriuretic peptide. Elevated natriuretic peptide is diagnostic in heart failure, but not the of major role, because differential diagnosis of elevated BNP as a cardiac causes, heart failure, acute coronary syndrome, pulmonary embolism, myocarditis, left ventricular arrhythmias, valve disease, cardioversion, defibrillator, surgical procedure, pulmonary hypertension, all may lead to high BNP. So the diagnosis of heart failure by BNP is of no major value. In non-cardiac causes of elevated BNP, advanced age, ischemic stroke, subarachnoid hemorrhage, renal dysfunction, liver dysfunction, and so on. Too much diseases. As regards the treatment of heart failure in the elderly, as well as the same as well as the treatment in the adult population. So this is the guidelines, the European Society of Cardiology guidelines for treatment of heart failure. As regard adult as well as elderly, no difference, but as regard the complications and the standard rule of the use of the medication in the elderly are vital and are sophisticated problem as regard the applications on introduction of medication in the elderly population. Take care from medication, because the patient may not die from the disease, but die from medication. And the medication rule in the elderly population, as all we know, start low and go slow. As well as say no. And if the patient take over medication, you can say no for this over medication. The co-drug administration and comorbidities are major problems in the elderly, and the management of the elderly must be taken in consideration properly. These are the guidelines of the use of the medication in the case of heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction. And this is systolic heart failure. Number one, the use of diuretic. The use of diuretic is mandatory and basic. But why we write it in this column and not such in these rows? These rows are the essential medication which decrease mortality of the patient as well as morbidity. Decreased mortality is a target. But the use of diuretic in case of heart failure not reduce mortality. What about the role of diuretic in treatment of heart failure? The role is just symptoms relief. What about the effect of this symptom relief? Yeah, there is the effect on the compliance of the patient, compliance of the life, dependency and independency in the daily lifestyle of the patient. The improvement of the symptoms are very, very important thing, as well as decrease the duration of hospitalization. And decrease the duration of hospitalization again is a target, because the patient with heart failure, 80 years old patient with heart failure admitted to the hospital, This patient may not die from heart failure and may die from nosocomial infection inside the hospital. So, the treatment in this case and the decrease in the hospitalization stay is a target by itself. So the diuretic in use of heart failure, diuretic use in heart failure may be beneficial, and daily use of diuretic is beneficial with precaution as regard the electrolyte and postural hypotension and etc. What about the basic medication to improve the quality of life? The therapy with ACE inhibitors plus beta blocker. These are the basic which decrease mortality as well as decrease morbidity, both. If the patient not improved on the ACE and beta blocker plus diuretic, we can add MRA. MRA is mineralocorticoids antagonists. The MRA may support the other medication which is not effective at all. What are the indicators for improvement in these patients? The indicators are, number one, as symptomatology, number two, as exercise tolerance, number three, as regard ejection fraction. This case, ejection fraction from start less than 40, and the improvement of ejection fraction is a target. If the patient not improved in these four medication, diuretic, MRA, ACE plus beta blocker, four medications. If the patient still not improved and the ejection fraction less than 35%, number one, replace the ACE or ARBs by ARNI. ARNI are groups of drugs, angiotensin receptor neprilysin inhibitors. What is neprilysin? Neprilysin is the hormone responsible about degradation of PNP in the body. Degradation of PNP and kallikrein in the body. So, in cases of heart failure, as we know, we may use in acute heart failure, acute cardiogenic pulmonary edema, may use BNP as a drug, niseretide. But in this case of chronic heart failure, no need to use niseretide, and there is some debate on it. We can use a drug which lead to retain of the natural BNP in the body, which is neprilysin inhibitors. This is the interest. So this valsartan, the ARNI present in the market is the valsartan plus cicopetrel. This is the interest, but in certain patients which are tolerable to ACE or ARBs. If the patient is not tolerable to ACE or ARBs, there is contraindication to use ARNI. May evaluate the need for a certain implantation, surgical corrections, underlying valve disease correction, underlying arrhythmia correction, and so on. And the third one to be used is ivabradine. What about ivabradine as a medication? In this case, if the patient ejection fraction not improved, ivabradine is ionic channel inhibitors and lead to depression of SE node. What about the role of depression of SE node? Mimic the beta blocker, which is depressed the myocardium at all. Depression of SE node is important factor in control of some cases of heart failure, which is not controlled by the use of beta blocker. And the last line in the treatment of these are tables that demonstrate some dose, and this is the role of pharmacologists, our colleagues. If no improvement until all these, consider digoxin, but digoxin again may increase the rate of mortality, and dangerous arrhythmia may lead to sudden death. So the use of digoxin in case of the heart failure as a last resort to improve ejection fraction, just only to improve ejection fraction and stop. We can use it for 1 month, 2 months only and stop, because it leads to sudden dangerous arrhythmia, may lead to sudden death, and use of nitrite or calcium channel blocker or vasodilatation, and lastly may use a cardiac transplantation as a last solving issue. Tips for drug treatment in the elderly. These are the take-home messages on this lecture. Older people may show an exaggerated drop in blood pressure after the first dose of ACE inhibitor, what is termed first dose hypotension. Again, the role here of the start low and go slow is mandatory. Check postural blood pressure frequently and renal function at intervals to monitor volume depletion and dehydration, especially during use of diuretic in old age, is mandatory and very common. Check serum electrolytes and magnesium replace when necessary, a very important issue in old age. Digoxin is useful in treat congestive heart failure due to systolic dysfunction only and not diastolic. Many older people will have some reduction in renal function, therefore give maintenance dose of digoxin on the basis of creatinine clearance. And if you can use digoxin in a short term, it is better. Digoxin toxicity can present atypical digoxin toxicity in the elderly with headache and other neurological manifestations. Take care from any symptomatology on top of use of digoxin in the elderly if you use and continue digoxin. This is an example of the scenario for discussing the cardiovascular diseases in the elderly. 72-year-old man is referred to you because of a precordial systolic murmur. Again, the most common murmur at all, the most common murmur in the elderly is calcific aortic stenosis. You must exclude calcific aortic stenosis if you auscultate any murmur in the pericardial area in the elderly. On examination, there is harsh mid-systolic crescendo murmurs at the right parasternal second intercostal space, radiating to the carotids. The patient is asymptomatic. Symptomatology is a very important finding in the case of calcific aortic stenosis. Patient asymptomatic, 72 years old, and you demonstrate murmur of aortic stenosis on the pericardium. Echo reveals an aortic area valve of 1.2, which means aortic stenosis. The aortic area normal more than 2.5. And mean systolic gradient of 30, this means systolic gradient normally less than 25. 25 to 30 is mild stenosis, 30 to 40 moderate stenosis, 40 to 60 is severe stenosis, above 60 very severe stenosis. What is the most appropriate intervention for this patient at the present time? What about the intervention? A case of calcific aortic stenosis in elderly, 72, asymptomatic, plus the area 1.2, which means a moderate stenosis, and mean systolic gradient 30, which means mild to moderate stenosis. So this is the case as a diagnosis of mild to moderate aortic stenosis, asymptomatic. What are the lines of treatment in such case? No medication needed, and no medication improve this case. And the line of treatment, they conserve and follow up, especially in asymptomatic cases. Patient with newly discovered aortic regurg and severe chest pain should be considered to have, especially elderly person above 65. newly discovered aortic regurgitation, and severe chest pain. This patient may be MI, pericarditis, dissection, syphilitic, ankylosing. Syphilitic and ankylosing, these two forms are lead to chronic aortic incompetence, chronic aortic regurgitation, and not acute, not newly discovered. Dissection, myocardial infarction, both may lead to acute aortic regurgitation, acute pericarditis not associated with aortic regurgitation. Thank you very much.